I am Dr. Shanti Narasimhan. I'm a pediatric cardiologist at the University of Minnesota, Masonic Children's Hospital. And I focus on imaging modalities, which is non-invasive imaging, fetal, transthoracic, as well as transesophageal echocardiography. I'm also the fellowship program director for pediatric cardiology. It's such a great pleasure to discuss on womb to tomb RV programmed in utero. Let's start with the introduction. What are our objectives today? I would like to go over the prevalence of maternal diabetes, overweight, and obesity, which is a very growing number and needs to be focused carefully. And at the same time, what happens to the fetal cardiovascular adaptation in utero when we are dealing with environments that are different from a normal environment. And also, what is the long-term impact of the offsprings? And then to go over some of the imaging modalities that is now opening the doors to understand cardiovascular disease itself. One of the focus topics now is on fetal cardiology, which has opened a window of opportunity to understand cardiac evolution itself. And also it's an opportunity to understand the impact of maternal status for the in utero environment onto the offsprings. We have known for the past 20 years, the prevalence of maternal diabetes has reached an epic proportion, particularly in certain racial and ethnic groups. The in utero environment is a key determinant for long-term health outcomes in children. Poor maternal lifestyle, like diabetes, metabolic diseases, and placental insufficiency are associated with negative effects on the long-term development of the children's health. It is estimated that 422 million adults are affected with diabetes worldwide. Among this, 129.4 million women aged 20 to 49 years of age are diagnosed with diabetes, and global prevalence of live birth affected by maternal diabetes is approximately 20.9 million. So, given this epic proportion, recent attention has been focused on preventive measures for atherosclerosis, which begins during childhood, and our goal is to reduce the risk of heart disease, stroke, and peripheral vascular disease later in life. For prevention to begin early in life, a non-invasive method to detect premature atherosclerosis would be useful so that intervention could be targeted to those at the highest risk. The process of atherogenosis begins in fetus and continues throughout the adult life. Echocardiography has given an opportunity as a non-invasive imaging tool to evaluate for compliance, arterial compliance. And we know that a decreased arterial compliance is one of the earliest detectable manifestation of adverse structural and functional changes within the vessel wall. The current understanding for altering maternal metabolic health and reducing the cardiovascular disease risk transmission to offsprings is limited and needs to be further studied. The first step to understand vascular changes of a fetus in maternal diabetes versus we need to compare to those who are healthy, non-diabetic mothers. So our work is not only clinically focused, but our work is mainly how do you translate the clinical work into a research-based focus, and then how do you implement that as a teaching tool too. So my passion is in fetal cardiology, and how do you translate everyday clinical data into a bedside research data also. So we started to think about how come when the risk factors we can look up in adults, maybe we should start looking up in fetal life. So we measured the intermediate thickness of the abdominal aorta of the fetus, as well as the aortic compliance and distensibility in the distal abdominal aorta in the cohort of fetuses in the mothers with and without maternal diabetes. We always have to understand the structure of a normal heart before we start to venture into a fetal medicine. The four-chamber heart is one of the most important organ to pump the oxygen-rich blood to the body and also receives the deoxygenated blood. And so we need to demonstrate these anatomical structures clearly in utero for us to actually look at the vascular data set. This is what we do at bedside. There's always an echo technician. There's a pediatric cardiologist who specialized in fetal cardiology, will be watching everything live. And we need one of the state-of-art echo machines, which we are using it as a Voluson machine, and mother laying comfortably, and the technician performs these ultrasounds. It's called the transabdominal fetal echocardiography. We can perform this as early as 16 to 18 weeks of gestational age to diagnose any type of congenital heart disease, and at the same time looking for certain things in research data pool itself. And we can perform as early as 16 to 18 weeks, and we go as far as late to about 35 to 36 weeks of gestational age. And here is an example of a four-chambered heart that I would like to show. Clearly, Voluson, the state-of-art machine, was able to pick up a good normal four-chambered structure with a cardiac function is normal. And we can see the valve morphologies, they appear to be normal. And these are the initial screening tool that has been available to us. And the second set of data that I'm presenting is a four-chamber heart. However, there's flow turbulence within the cavity space itself, which is concerning. And this is what we started seeing, changes that's happening within the myocardium itself. The myocardium in maternal diabetes is very, very thick. There is ventricular hypertrophy, which is already starting to show changes in utero. The myocardium has started to see changes. It is quite significant compared to a non-diabetic mothers. And the next picture shows you a normal short axis view of biventricular structure. The top is the right ventricle, the bottom is the left ventricle, and we can actually measure the thickness of the myocardium based on the gestational age. If a fetus is presenting at 20 weeks, normally the myocardium thickness should be 2 millimeters. However, when moms have diabetes or they have uncontrolled diabetes, what we can see is the myocardium appears to be very hypertrophied. For a 20-week, the myocardium measures about 30 millimeters or 3 millimeters. So it's very thick. You can see the obliteration of the cavity. And there is evidence of systolic as well as diastolic dysfunction of the myocardium. And we went further. We started looking at the vascular structure. That's the easiest structure that we can see very clearly is the fetal abdominal aorta just at the bifurcation. So we took a cine clip of the abdominal aorta of the fetus from both the mothers with diabetes and without diabetes, and started to look at arterial compliance as well as distensibility compliance, the area changes. At the same time, we started looking at any evidence of intimal changes that's happening. This is roughly about second trimester we started looking at. And once I get this data set in a cine loop, we send this images to our vascular lab, where with a very specialized software, we can look at the vessel compliance, distensibility, as well as the cross-sectional area changes can be easily be looked at it very carefully. This is actually the first study in the literature discussing about vascular changes compared to a diabetic mother versus a non-diabetic mother. And the software itself will be able to give us the data set. So our study looked at feasibility. Is it even feasible at second trimester to look at these changes? And what are the initial changes that's happening in utero when there is high levels of sugar within the amniotic fluid, at the same time within transmission within the placental transmission to the baby. So we looked at 16 fetuses of a diabetic mother compared to 25 of a non-diabetic mothers. And this was initially a pilot data, and we had some funding to be extended so that we are collecting about further data set to see any changes that's happening as early as the second trimester. So we looked at the demographics. The diabetic mothers versus non-diabetic mothers, their ages were similar, 31 plus or minus 4 standard deviation, compared to the non-diabetics were 32. The heights were pretty much the similar. However, we can see a significant difference in the weight itself. The diabetic mothers weighed pretty higher, 84 plus or minus 22, versus a non-diabetic mothers were 72 plus or minus 14 with a p-value of 0.07. And also we saw evidence of BMI changes too. The BMIs are much higher in the diabetic mothers compared to a non-diabetic mothers. So this is the first study to show that it is feasible. First of all, it is feasible to measure the IMT compliance, distensibility of the fetal abdominal aorta in the diabetic mothers compared to non-diabetic. The interesting finding is that the fetus of the diabetic mothers, for some reason, the arterial compliance was much greater than the non-diabetic mothers. And the exact reason of these type of differences is not known. However, it is possible that there is a period of adaptation or an arterial remodeling that's going on. It starts with initially an increased compliance, which we did not expect, followed by may develop before an arterial stiffness or a lower compliance starts to develop. So this potential prenatal cardiovascular remodeling may set the stage for vascular changes and cardiovascular risk that will need further investigation. So this is kind of a clinical work that is being translated into bedside research to give us some answers. How do you start preventing rather than starting to manage certain things? This is one of the work that we do. But our most important other clinical works that we do is how do you work as a multimodality team, multidisciplinary team. Here's an example of how we can all work together as a clinicians. Is one, a fetal echocardiography shows there is increased of the left atrium. It's a left atrial aneurysm that we have shown in several different multimodality imaging from fetal life, and then translating into postnatal echocardiography. The arrow points at the aneurysm of the left atrial appendage. We have done a CT, and through the Visible Heart Lab, we had a 3D reconstruction model, so that it becomes a dry run for the surgical team as well as the operating team to say exactly how much of resection needs to happen. And so here's an example of surgical tissue that was a surgical specimen that was resected after we had done a CT modeling as well as a 3D model through the Visible Heart Lab, and then is the surgical picture, which this was also reported. And these are very few cases that are reported in the literature, which is important to report these kinds, because when we started looking at this data set, we could not find it. We could not find several cases in the literature. So this was one of the cases right now that's available in the literature. The other things that we do from fetal echocardiography is one of the rare cases, what do we call it, as ectopia cordis, where the heart is completely outside the body. It's outside the chest cavity. And we actually picked this up in utero. It's a very complex scenario where the heart is in the amniotic fluid. So this is a fetal echocardiography with the heart being outside. And we had to monitor during the pregnancy very carefully. And there was a 20-member team which was put in place for just one child and for the fetus. And there were 2 operating rooms that were available where the mother was delivering, and then the baby was transferred immediately to the operating room next door, where we had a combination of neonatologists, maternal fetal medicine physicians, pediatric surgeons, cardiovascular surgeons, plastic surgeons are all available at a given time. And to have this kind of tertiary setup brings in a significantly great outcomes. And this is one example of a teamwork that was done where the heart cannot be placed inside the chest because there's not enough space in the chest cavity. Initially, the heart was wrapped in a Gore-Tex material. As the child was growing, the plastic surgeons were able to extend the skin from the baby itself and try to close the open incision that was in utero, had a congenital deficiencies, and then a cage was built as part of the chest cavity, and the child needed tracheostomy, has a G-tube in place, and has been doing very well. So here is an example of a multidisciplinary teamwork. The next one is a very complex single ventricle physiology that these days, at this point, we need to pick up any congenital heart defects in utero as early as 16 to 18 weeks, and we create a multidisciplinary team. This is a complex single ventricle where the team consists of maternal fetal medicine physicians, pediatric cardiologists, pediatric cardiac surgeons, the neonatologist, cardiovascular intensive care physicians, social workers, and the baby will be, the team that is involved consists of early diagnosing team, the team that diagnoses initially, and we plan for pregnancy. The planning pregnancy means we care for the follow-up care to look at the evolution of cardiac defects in utero. And we deliver in a tertiary care setup where the team is available 24 hours a day, if necessary, to go into the operating room immediately, and will be transported to the neonatal intensive care unit where the initial workup needs to be done, and we'll be presenting all the data is being presented to the cardiovascular team, and the child goes to the operating room for a staged palliation. So these are some of the work that is done at the University of Minnesota Children's Hospital. And we have the state-of-art setup for VAD program, as well as we are the Center for Heart Transplant team. So I think it's important to have a multidisciplinary team approach to any type of heart defect, any type of congenital heart defect. To have the key is to have a successful outcome, and that's what we are showing it. in our work here today. Thank you very much. Appreciate your time.